Good morning, everyone.
Good morning.
Good morning, everyone. Thank you. I'm Edward Godari. I'm with the Department of Mental Health. I'm the district chief. He's the regional manager for SPA 4, this area that we're now sitting in, of course. This is Jim Gilmore, and Jim and I are going to be talking together with you about a few issues. I'm going to let Jim introduce himself in just a moment. I've been the district chief of the Department of Mental Health here about 3 years now, and before that I was the district chief for several years. Actually, it's been longer, that's like 4 years. And before that I was district chief in SPA 7 before coming here. Jim, you have to say a few words about yourself before we launch into...
Good morning. My name is Jim Gilmore. I'm the Director of Corporate Development and Training for Behavioral Health Services. We are a large provider of substance abuse and mental health services in the county. We've been doing a number of these things for years. The BRIGHT program is a project that we've been working on for the last 4 years. It is a research project that we've been working on with RAND. And the results have been extremely promising. We're about ready to publish the final results of that in the next coming year, but what we've seen so far has been really effective. We do have a couple of the counselors that were trained in the BRIGHT program here today. They're going to be part of the CBT workshop later on. I just want to say real quick, because in this discussion, I'm going to kind of represent the CBOs, those of us that are out there in the community trying to keep our doors open and to provide services with shrinking dollars constantly. We're all aware of what's happening at the state level, and it's making it really difficult to do what we do. One of the things that happens is what was mentioned earlier, that when you get funding, especially public funding for anything, it comes with some regulations and restrictions, which kind of by its nature create these silos where you're kind of only allowed to do whatever it is you do, whatever it is you're funded to do. And at least out in the community, many of us have been forced to kind of figure out some ways to get around that barrier, because funding has kind of become a barrier rather than a help to us in a lot of ways. So we've had to really look at how can we work together, how can we find other folks who do some of those things that we need that we can't do because we don't have the funding to do. So that's kind of how we get involved with this whole collaborative process, and it's kind of gone on from there, and I think that's something that we want to talk more about today. So,
Thank you. The Department of Mental Health, of course, receives funding from the state and the federal government, and of course we get some funding from the Board of Supervisors. But we too have been struggling with shrinking resources, as you all know. Many of you are providers who are contracted with our department to provide mental health services in the community. So what Jim has said is true not only for CBOs, but also for county departments and the agencies that work for them. And yet within these limited resources, we've been trying also to do many of the things that Ken and Elizabeth were talking about earlier. We've been trying to collaborate with others, to create a fuller connection with other services, because we clearly understand that people don't get better concerning their mental health issues if they're struggling at the same time with housing and unemployment and education problems and all the other problems that can be confronting a person. So we've been trying to put those things together. So we're so happy to be working with Ken on this pilot, because it's right in the direction that we've been trying to go ourselves already. Now, if you've looked at your schedule, you'll notice that the reason that Jim and I are here talking is to address, to lead a discussion about the issue of depression care in our community. What are the issues, the problems, and the potential solutions? So that's the focus we'd like to bring today, and ask you to join with us in a conversation about what is the state, what are the resources that we now have in the community. And maybe to really bring it home, to ask yourselves this question, and then I hope you can share with us your perspective. And the question is, how are you today handling you today addressing depression when it comes to your attention? How do you help the person with depression when it comes to your door? What are you able to do today to address those needs? Can I turn to you and ask for some volunteers to share with us what you're doing or able to do? Yes.
And this is a very common experience for me, that clients come in, and I don't find that many are in denial about depression. They use the right word. They say, I'm depressed. I have to honestly admit, I've been doing this work. I'm a parish nurse. I'm a nurse who works in churches. That my internal thought is, oh no. Because I'd rather have hypertension. You know, I can send them to a clinic. It may not be easy to get them to get in. With depression, of course, one part of it is trying to listen to them, just show some empathy. Sometimes that helps. They come back and they seem to like us. They come back. That's one sign there must be doing something. How they're coming back for more. But I also have clients waiting, and it's not much privacy, so they only get a few minutes of whatever empathetic listening I give in a very unprofessional way. But what I also try to do then is send them somewhere. Like, is this a big enough problem that you would like to do something about this, like go somewhere? Then the question is, where can I get them? And when I call, I often find, when no one answers, I find they don't quite qualify. I find that yes, they're available to have a service, but it's a long time in the future, or that it costs more than they can afford. So I often end up, encouraging. I work in churches. I say, well, there's a church here. There's always prayer, and there's always a pastor, and that's a resource available nearby. And one I know they're comfortable with because they're always showing up in churches. They're pre-selected in that way. So, I think it's a lot better than nothing, and I think it could be a lot better than it is.
So just to recap, stereo. So just to recap, you do listening, empathetic listening. You provide support. People return for a second visit oftentimes, or even third and fourth visit. You try to make a referral, which sometimes works and sometimes doesn't. And you turn to the church, prayer, the support of the community that is the church. And those things all help.